Okay, and if we could do the second poll that we've got, the Slido that we've got, please. What are your main concerns at the moment? We understand the assignments, but if you have no concerns, that's fine. If there's any concerns you have about completing the course or anything you need, please pop that in there. If there's any information needs that you have, if your concerns are you can't find information on a certain topic that you're doing for your assignment, or you can't find information on an improvement that you want to make, please pop that in as well. But we do understand you're all concerned about the assignments, because I would be as well if I was sitting in your shoes. It's a natural thing to be feeling, so please don't worry about that. Okay, I see some people are typing, so we're just going to wait for that. Finding up-to-date references. Time, I feel it's been too condensed. Okay, well, whoever's popped that in about the time, the time I feel it's been too condensed. Please, can you pop that in the evaluation when we do the evaluation for us? The person who's put in their finding up-to-date references for assignment, if you can pop in the chat for me what subject or subjects you're struggling to find up-to-date references for, and we'll see what we can do to help. Okay.
Sorry, Chris, I have one question. Like, I'm not able to type in the slide, so where do I go for it? Where do
in the chat, if you at the bottom of the Teams thing, there should be something which says chat.
Yeah. But
Yeah.
is it the
If you
slide
pop,
thing?
sorry, oh, the Slido. Don't worry about the Slido now.
Okay.
That's fine. Don't worry. Unless there's anything you know, you can pop anything in the chat as well if the Slido's not working. That's fine. Right. Does the references have to be current or up to what year? Right. Okay. Winnie will say in all the stuff, and all the universities will say, try to look for references within the last 5 years. Now, we know within infection prevention and control that is not always possible, because some of the research has been done a while ago and hasn't been repeated. So if you cannot find up-to-date research, there are 2 ways you can go around it. You can use research that is slightly different, but that you can make the argument that it would apply to the area that you're looking at, or you can use the older research and make the argument that it's still current and no further research has been done, and that's the reason why you're using it. So it shows you're critically evaluating it. But for example, if you picked up a piece of research that had been done, say in a nursing home, and had been done 20 years ago, you would have to make the argument as to whether that is relevant, because things have changed. I mean, when I first worked in nursing homes, which was a long time ago, you wouldn't even have had anybody there then that had peg feeding or that kind of stuff. So you have to make the argument that things are still relevant, even though something might have changed. Right. I'm looking for resource which either supports or is against admitting a patient into ward 6 hours after a discharge, and resource for the effect of cleaning materials. I don't think you'll find anything about 6 hours particularly, but there will be stuff on cleaning materials. Now, I'm going to have to put this in the discussion page, because this is going to take a little bit of thinking about the effects of cleaning materials. I will see where I can direct you to the right resources to look at for that, to try and help you with that. Okay. Right. You still do have, yeah, we can close that down now, I think, Crystal. That's okay. Thank you. Right. If you still have queries and questions after this, like I said, please pop stuff in the discussion group. That's what it's there for as well, or email into the IPC email address, and we'll see if we can help you with it. Okay. So unless there's any further questions, there's a message for everybody as well. Looking for current resources on catheter-associated UTI. So if anybody has found any on that, please do let us know. If not, we'll have a look and see what we can find. Okay, that's for Riza. Okay, right. So I'm going to move on to the sessions that we're doing today. And our first session is on leading and communicating infection prevention and control. So what we are going to be doing in today's session is we're going to be looking at why leadership matters in IPC. We're going to be looking at how you influence people, your senior leaders and your colleagues, and how we communicate messages about IPC, because a massive part of the role is the communication, whether you're in a specific IPC role, whether you're in a linkness type role, whether you just have an interest in this, whether you have particular accountability for it. The communication is probably one of the biggest things that you need to be able to do. So let's start off by looking at leadership in healthcare in general. And I'm not going to spend a lot of time talking about general leadership, because I'm sure a lot of you have already done leadership courses, and there are masses of resources around leadership in healthcare services that you can access either through the library at the RCN or through other sources. But one of the really good areas to go and look around leadership stuff is the King's Fund. And I have given you this reference here. And the King's Fund did this statement, this position around leadership in healthcare. They've done a lot of work around this. And what they say is that where you've got good clinical leadership, you get higher productivity and better organizational performance. So it reinforces the fact that it's important not to just have people with management skills in leadership positions, but people that have got that clinical background as well. And they looked at the different types of leadership, and they feel very strongly and have done a lot of work on compassionate, inclusive and collaborative leadership. And their view is this is really essential to deliver the highest quality care for patients. And that's based on the evidence from what they've reviewed, the literature, etc. with this. And 4 key areas here that they refer to. The first one they call attending, and they call this listening with fascination. And this is about taking time to listen to the challenges, obstacles, frustration and harms that colleagues experience, as well as listening to accounts of their successes and their joys. So it's listening and hearing, really, rather than just listening without understanding what's going on. So the understanding here is about taking the time to explore and understand the situation. And that for the King's Fund is about valuing and exploring conflicting perspectives rather than leaders simply imposing their own understanding. And this is one area that I've been very, very keen on in the past when I've been in leadership roles, is making sure that the team around me are not necessarily mirror images of me and how I work. I'm an extrovert, as you probably would have worked out, and have a few particular traits. And I always like to make sure that I balanced our team with people who thought differently, operated differently, and weren't necessarily afraid to speak up to me as well. So it's really, really important that you explore what other people are thinking, not just using your way of doing things. Another way I can explain that as well is I'm very much one of those people that sits in the middle of the implementer innovator scale, and I can usually see a solution to a problem. But we know that there is always more than one solution and way to get to that solution when we've got any problem. So I very much had to stop myself going in and directing people with what they wanted to do, and sitting back and letting people come with their ideas, and letting them direct the journey to where we got there. Empathizing, mirroring and feeling colleagues' distress, joy and frustration. So just working with colleagues to understand how they are and supporting them there. And then with helping, what this really means is removing the obstacles that get in the way of people doing their work. And examples of that could be excessive workloads, conflicts between departments, and also helping people with getting the resources that they may need. And those are particularly important tasks for leaders. Don't know if any of you have ever watched the New Amsterdam series. I think it's on Netflix at the moment, and it's been on Prime, etc. And Max, the medical director, the first thing that he started to ask when he came into the organisation was, "How can I help you?" It wasn't coming in and saying, I need you to do this. It was, how can I help you? So that's quite a good phrase to remember when you're a leader, is to always ask what you can do to help people do what you want them to do. Now, moving on particularly to IPC, the National Institute for Health and Clinical Excellence have quality standards which set priority areas for quality improvement. And they have one for infection prevention and control, in which they have statement 2, the organisational responsibility. And that's the statement there. Basically, what they're saying is that leadership underpins all infection prevention and control. What they don't do is tell you what that leadership means and how to do that. They just make a bold statement about leadership. So let's look at the literature specifically around leadership and IPC. And it's starting to become developed now, which I think is really, really good. When I first started my career in IPC, there was very little on leadership that related to IPC. You had to use general leadership studies and apply them across. But there's this is one of the ones that I'm going to tell you about here today. This is an Irish research study, and they were looking particularly at implementation of guidelines for MRSA and Clostridium difficile, as it was in those days, Clostridioides difficile, as we know it is now. And they did surveys and interviews. The interviews were qualitative and the surveys were quantitative. And they were asking what supports and doesn't support being able to implement policy into practice. So that's what they were particularly looking at. How do you put policies for MRSA and CDI into practice? And the conclusions that they came up with from this were that guidelines are complex interventions, we know that. Leadership could help overcome the challenges posed by this complexity. And they also found that guidelines present can present an ideological approach to care, which differs from the contextual reality of clinical practice. The theory practice gap to a certain extent. And what Susie was talking about yesterday, it's about when guidelines are written, it's about going to the front line and asking them if these will work. And that's the same with implementation. It is, how are we going to get this implementation across? And what they found was that if you've got good leadership, that can help a systematic approach to the implementation. So having a structured way to do that. And this is what you're really doing as part of your service improvement projects. You're looking at a systematic approach to how you make that improvement. And it might do the sustainability good as well. So it might help with the sustainability, because often when guidelines are put in place, they can slip back over a period of time. So important things there: leadership to help overcome challenges and to help with sustainability. Now, this study that was 2010, so okay, it's older than you would normally be expected to be putting in your assignments, but you can justify this by there's very little that's been written on it. And this was done in the United States. And they looked at successful leaders where hospitals were doing particularly well with their healthcare associated infection programs. And they purposefully sampled those hospitals. So what they didn't do was compare this to ones that weren't doing particularly unwell. And they did qualitative interviews and then semi-structured interviews for this. So what they found is the successful leaders cultivated this culture of clinical excellence. Now, I think there is sort of a fine line is probably how I would describe it. as how you do something like this. It's setting those expectations about what is excellence, but not being so prescriptive that if it's not possible to completely achieve those, that you criticize people or that staff get in trouble over it. It's striving to have clinical excellence at all points in time is what I would say there, really. So that culture there. They communicated it well to staff, and they had a number of different ways that they communicated it using all different methodology there. They focused on the overcoming barriers, linking that back to the King's Fund, where they said there about the compassionate leadership, that people that overcame the barriers were better leaders. They dealt directly with resistant staff or process issues that impeded prevention of healthcare associated infection. Inspiring colleagues, which I think is a really important thing for you guys when you're going back into the workplace. Every single one of you is a leader for infection prevention and control. You're here doing this course. Doesn't matter what role you're in, you can inspire everybody that you work with to do better with their healthcare associated infection. And they thought strategically whilst acting locally. Now, what that means is they politicked with a small p before any crucial committee meetings or presentations or anything, or anywhere where there might have been a vote on things, so that they had people on side before they went into the meeting. Now, some of you will be in very senior positions where you will have to do this and where you will be doing this. Others of you will be implementing at a more frontline level. So it's still thinking about that strategically. If you're trying to make your change in practice, who is the person that you can influence that you work with that will help you to do this? So that's the thinking strategically whilst acting locally. Now, again, this is another US study, and date-wise, this would fall into what you legitimately can use in your assignments. And this study looked particularly at catheter-associated urinary tract infections and central line-associated bloodstream infections, and looked at those, again, that were doing well and weren't doing quite so, and not doing quite so well with this. So they interviewed 420 people in 18 US hospitals. So possibly a small sample number, if you look at the number of US hospitals that there would be, but 420 people were interviewed there. And they analysed the interview transcripts using qualitative methods. And what they found from this, the important things were engagement of the executive leadership. So having your senior people on board, and with them being visible, showing a commitment and an involvement. Now, when I was the lead infection control nurse in DIPSI for the IPC at University Hospitals Bristol, Bristol Royal Infirmary and the other hospitals around there, we had a big problem with Clostridium difficile. And everybody thought that this was something that was inevitable because we had older people coming into hospital and they were on antibiotics. My chief nurse agreed with me and our microbiologist, our lead microbiologist, that we really needed to do something about this. She cleared her diary a day a week, and a day a week she focused her whole time on CDI, and we made a dramatic reduction in it. She was visible, she showed commitment, and she got involved. The information sharing here, they found that emails, bulletin boards, huddles, all different ways with how you can share information are really, really important for facilitating your programs of HCI in prevention. And the last one there, manager coaching. This was how the managers and the immediate leadership at clinical level operated. And those that operated in a coaching way, using feedback and real-time education, they made better improvements. Now, you guys have all had coaching now as part of this program. So you know how to operate as coaches yourself. So you can think how to use that when you're back in your workplaces for how you can show that commitment to people and make improvements in HCAI. Now, this is carrying on from that previous study. It's part of the previous research study. With big studies, you will often find that different parts of the study are reported in different journals or in different articles. And from this one, they did site visits and did semi-structured interviews here. And again, it was the catheter-associated UTIs and the central line-associated bloodstream infections they were particularly looking at. And they paired together the higher and lower performing hospitals in this one so that they had comparative data. And the principal findings are actually quite similar to what they reported in the other study there. So there were three themes: the leadership support. So you had the engagement there, the frontline staff being involved, the participating in improvement huddles from the senior leadership, but having the financial and human resources input to it. Recognizing successes, positive feedback, emails, newsletters, celebrations on units. I know some areas have stuff displayed about so many days between certain infections like bloodstream infections, so many days between pressure ulcers if you're looking at another area of improvement that this can work in. But they also did celebration here for when the staff did particularly well. So they did things like gave them pizzas or got them unit fleeces or hoodies, that kind of thing. So what they found was that recognition was as important. So the carrot was as important as the performance information was. And then having very, very clear goals that were set, that staff could recognise, that staff knew what they were. And again, they reinforced this with the visual reminders, which I was talking about, like so many days. How are we doing? Like the how are we doing boards is basically what we're talking about here. So let's think about how we put this in practice. So how do you influence your senior leaders? Because you've got to think about a whole range of people that you're going to need to influence with your HCI improvements or when you're implementing a new policy. So being clear about what your objectives are, setting clear objectives when you're doing any pitch, and linking it very clearly to the focus of your organisation. Well, all of your healthcare organisations should be focused on safety. So you can very clearly link your HCAI to any safety goal. Approaching persuasion as a process. This is about building your relationships with the right people that you know are going to help you with this. So knowing which of the leaders are going to be the ones to get involved with this project for you. And when you do, you need to make sure that you show them that you understand that they have other problems as well and challenges. And don't be discouraged because you will come across bumps in the road. So be persistent and don't be put off. Selling your idea is about how you plan your key messages according to who you are talking to. And it may help to do the politicking thing here about meeting with the key influencers beforehand. Storytelling is always a good idea. So if you can link it to events that happened with a story, that can be more powerful in selling your message than the evidence can. You always need your evidence to back it up sometimes, because particularly in healthcare, our medical colleagues can sometimes be hung up on what's the evidence behind this. So the sessions you have with Dinah will be really helpful for you to be able to have some of your evidence there, but be able to talk about why some of the evidence isn't available. As she said, we don't need to do a parachute study to show that if you jump out of an aeroplane when it's in the sky, it isn't going to do you any good. Being prepared to defend your idea. Being able to link this to how this is going to benefit the organisation. And organising it so that it's easy to understand. That's why you're going to do your elevator pitch to your colleagues in the group work, giving you a chance to practice this in a safe environment. Anticipate tough questions and prepare solid answers. I don't know if any of you watch The Apprentice, but it is absolutely the program to watch to know sometimes how not to do pitches to people when you're trying to sell ideas. They go out and they do market research and they come back with all these criticisms of things. And then sometimes they don't follow it through and talk about how they are going to change and modify in accordance to this. They just don't have the right answers to it. And the people they're pitching to know when they are selling them a line and when it's not anything that has any substance to it whatsoever. And lastly, there's painting the picture of beautiful future. Tell people what the good is going to look like so that they can see that. You'd be surprised how many people can't see your vision. You can see your vision, but not everybody can see that. So if you can paint that picture about what it's going to look like, and within that, outline the steps you need to implement your plan, and ask for the support that you might need. Be prepared to ask for that, because it's no good if you're going to senior leaders going with a presentation like this. They need to know what you want them to do to help them. So it may be that you're going in and you're saying, well, I would like you to perhaps come to 1 or 2 huddles with me, or I would like you in the chief executive's message to include this in a couple of months' time. So that's how you influence upwards. When you're influencing your colleagues, you need to listen first. So ask for perspectives and advice. So your stakeholder analysis is a really great thing for this, because you will have thought about who needs to be involved and what is important for them. Body language is really quite important. I'm a naturally smiley person. You will have noticed this as we've been doing these sessions. And we had a problem in the hospital when I was DIPSI, Director of Infection Prevention and Control. Our cardiothoracic surgeons had end of year gone out and spent loads of money on some scopes that we didn't have the facilities to decontaminate them in the organisation. And I had to stop them using them. So the lead cardiothoracic surgeon was not very happy about this, as you can imagine. And he went to see our lead microbiologist, Bob Spencer. And we sat and we talked about this in the office. And all of a sudden, he got really angry, the lead cardiothoracic surgeon, and said, look, she thinks this is funny. She's smirking about it. Just because I'm naturally smiley. So that was really, for me, very important, how I have to think about how my body language comes across. And it's very hard when you're naturally that kind of person, that sometimes your natural exuberance, you've got to sort of dampen it down a little bit. Voice pitch, important. Knowing your subject inside out. So you will get asked awkward questions about these things. You know your subjects because you're doing all the research on it, which is great. Think about who has the most influence, as I've already said. Think about how you can frame this, give people what they want, considering the what's in it for me. Consider how you can frame your idea as a benefit, not just for the patients, but how it will help the people that you work with, because that will help influence them to come on board with this. Now, when you're doing your safety messages, there are ways to get the message across that will hit harder than if you do it in other ways. So simple messages will have a bigger impact. So keep it short, sharp. If you think about the flu and COVID, catch it, kill it, bin it. Phrase your messages with precision. So being brief, being credible, so that there's no contradiction and confusion in them, and focusing on those few elements. The rhythm and symmetry is quite important. The catch it, kill it, bin it. I don't think there's many of you on this call that are old enough to remember before seatbelts were worn in cars. And the public campaign about that one, which was plunk, click every trip. So rhythm and symmetry. You think about the children's safety messages about look, listen, cross when safely. It's short, sharp, rhythm and symmetry. You can use innovation in here to help the motivation. And I'm going to show you some ways that you may well be able to do that. Keep your message positive as you can. Think about visualization, because that improves memory recall, and include the people that you're talking to through questions with them. Make it interactive more than it is about you and your spiel. Very hard when we're doing these sessions for me to make this interactive. If we were sitting in a room now, I would be talking to you about how you do these kinds of things. And it goes back to the relate importance to people's needs and ambition. Why do we need to be doing this? What is the importance of this message here? So using humour can help you to convey your IPC messages. Now, in past courses, I've had people say, but my manager has said, this is dumbing down infection prevention control if you use humour. Well, I have the evidence base for you. Well, a little bit of an evidence base to show you that humour is an effective method for this. Now, this is a fantastic YouTube video to go and watch. It's Didier Pité again. If you remember back to Dinah Sessions, Didier Pité is the hand hygiene king, basically the alcohol gel, the one in Geneva. And this is a fantastic YouTube video that I'd recommend you go and watch. And he makes the argument for how you use humour in IPC. And the key points are effective method to attract attention. Humour and positive methods encourage, promote behaviour change and knowledge acquisition. And humour strength and humour message relatedness have a positive impact on memorising the message. And within that, he uses the evidence base to support it. But I'm just going to give you one of the pieces of evidence that he used, and I think I put this reference in the reference list for you. So it was at Geneva Hospital again that they did this, and they assessed learning, the outcome and secondary outcome of watching a 5-minute humorous edutainment. So it was a video, and they called it edutainment because it was education and entertainment on standard precautions compared to reading a written standard operating procedure or receiving no intervention. And those that saw the 5-minute video were more likely to have satisfaction with their learning experience and would recommend that method to their colleagues. So there is pieces of research that you can use to support you using a humorous way to do IPC. So what are the practical things that you can do? Well, there are participative activities that you can use. The picture at the top left of the screen there, shaving foam. Get people to put an apron on and gloves. You can use masks as well. And then get them, cover the front of their apron in shaving foam, and then get them to try and take it all off without getting shaving foam on them. You can put the shaving foams on their hands and show them how difficult it is. I expect a lot of you have already used the glow germ where you've got the ultraviolet on the hands, etc. Very, very participative. Isolating iris, if you ever have any empty rooms or cubicles or seating areas, you can set it up with infection control infractions in there. We did this and we had a model in the bed, a dummy in the bed. And you can have things like the catheter bag dragging on the floor. You can have a cannula that's been in for more than 72 hours and not monitored, etc. Word searches, quizzes, card games. If any of you have ever played like the Happy Families game where you have to match Mr. Bun the baker, Mrs. Bun the baker, etc. with their families, you can do this with microbes. You can have, say, MRSA, and you know, you can teach people with it and say, you know, it's a gram-positive coccus. Where do we find it in the environment? How does it spread? So if you think of your chain of infection, you can do this with microbes. There were commercial products, card games on the market at some point. I'm not sure if they're available now, but you can make these up very easily yourself. So whatever are the microbes that are a problem in your area, you can get them to do this with a matching game. So that's some ideas for you guys about what you can take forward. What we're going to do now is we are going to go into your groups and we're going to get you to do your elevator pitch to your colleagues. So the next session today is about, it follows on really from the last session, and it's about raising concerns and having those difficult conversations because we've all experienced that, I'm sure, in the workplace, as how we've come across practice that might not be appropriate, or something that's not gone right. And for IPC, the consequences when things aren't right can be quite significant and severe, as with a lot in healthcare. But my first question before we move into it is: anybody on the call a freedom to speak up guardian or lead in their organisation? No, nobody. That's a shame. I would have used your experiences if any of you were. Um, so yeah, we'll carry on then, and we'll do the session. My mouse has now decided to play up. So I'm going to share my screen and we will start the session. Okay. You just organise everything again so it's out of the way, so I can get to things. What we're going to cover in this session, we are going to look at why and how it's important to raise conversations, and we're going to look at having difficult conversations and some frameworks that can help with those conversations. And then we are going to do a little bit of group work about difficult conversations. So let's start off by looking at why it's really important to have a culture for speaking up. And the first, oh, sorry, I've gone the wrong way. Let's go back. Right. First thing is, it can reduce harms and costs. So it's really important that if we see stuff going wrong, that we're able to raise it. All the things you'd expect to be here, the safety of our patients and our workers, but it actually helps the organisation by making it a place that people want to work, because they see that things happen and see that things change when concerns are raised. And it's better for the organisation all round. So there can be no doubt about it. A speaking up culture is what we want to have. Just a little bit of a reminder for you that I think everybody on this call is nursing midwifery registered this time, but just a reminder about our responsibilities under our code of conduct, whether you're a nurse or whether you're another healthcare practitioner, that we have a responsibility here to raise these concerns. And if concerns are raised to us, we have a responsibility to act on them. So it's not just a nice to do, it is part of our professional responsibility. But it's not all that easy to do. If any of you have tried to do this, you may have come across some of these reasons. And there's a whole list of things, as you can see there, that for the reasons why people don't speak up. And this is a survey of all employees. It's not just NHS employees, it's a survey of everybody. But the interesting thing from the National Freedom to Speak Up Guardians office in England, they do a survey of the Freedom to Speak Up Guardians, the leads that are in their organisations. And in the 2023 survey, 2/3 of them said that people didn't speak up because they didn't believe the actions would be taken. And that has increased since they did their first survey in 2021. So there's something going on at the moment in healthcare around speaking up and actions not following behind it. Possibly financial, possibly because when we were with COVID, everything was thrown at it to protect everybody then. We don't really know. But it's people don't necessarily want to be troublemakers either, and people have seen serious consequences to themselves when they've spoken up, and it's even gone as far as tribunals. Michelle, oh, his surname I've forgotten. I will have to find it for you. It wasn't an IPC speaking up, but it was about ethnicity and being discriminated against, and she spoke up, and she was dismissed, and she took NHS England to a tribunal over that and won the tribunal. So there's lots and lots of reasons why people don't speak up, and the evidence from England is that for the global majority, it can be even harder. So white people, white staff have been able to speak up appropriately, but from the global majority, they find it even harder. So we need to be aware of this. They didn't think they'd be understood, didn't think they'd be taken seriously, didn't understand what the role was all about. So really, really crucial that we think about all the different groups that we have in how we encourage them to speak up. Now, when it goes wrong, it can go seriously, seriously wrong. Now, the top one there is the Francis inquiry, and that was Mid Staff's Hospital. I know that's 11 years ago now, but it's still quite a seminal inquiry that happened there that people need to be aware of. And if any of you have ever read the Francis Inquiry or know anything about it, there's some horrific stuff that was in there. Patients drinking out of flower vases because they didn't have water, patients dying, staffing had been cut back because the trust was going for foundation status at that point in time. So the wards were seriously understaffed, a little bit like it's happening at the moment. And I know there's some people that are scared that another mid-staffs will happen. But with regards to speaking up, the fear factor, one of the key people in the inquiry said the fear factor kept me from speaking out, plus the thought that no one wanted to know. Links back to that 2/3 didn't think that anything would happen, according to it. Morecambe Bay up in the northwest of the country, and this is related to midwifery, maternity unit specifically. And there was a baby that died, Joshua Titcombe, and his mother and father didn't let it rest. The father was absolutely adamant that something had gone wrong and the organisation were covering up what had happened to their baby. And he pushed and he pushed and he pushed, and eventually an investigation was done into Morecambe Bay, into the maternity unit there. It was a midwifery-led unit, so it didn't have all obstetricians there. So there was a midwifery unit and there was a obstetrician-led unit as well. And the relationships between the people in these units, the midwives, the obstetricians, and the paediatricians, were completely fractured. And people had known about this, the staff had known about this, and were speaking about it internally, but they had no systematic way to warn those in more senior positions about what was happening. So whilst they were talking to themselves about what was happening internally, they didn't, as a group, raise any concerns. And the other significant things there was a huge focus on natural childbirth. And mothers weren't escalated up to doctor-based care when they needed it. So a reliance again on own professional practice, not working together. Gosport Bay down in the south of the country. This is a community type hospital. And there was the local GP practice, one GP from that practice that was responsible for the oversight of this hospital. And there were concerns about people being given high doses of opiates, older people, high doses of opiates, and dying because of it. And the investigation found that, yes, these people shouldn't have been given the levels of opiates that they were being given. And the nursing staff did try to raise concerns here. And there was a response back from both the management and the clinical leadership, which was medically dominated. It was inadequate, and there was a culture of doctor knows best. So they did try and speak up, and when nobody listened, it went drastically wrong, and a number of deaths associated with it. And the last one down the bottom there, I know it's 20 years ago. This is Stoke Mandeville Hospital, where I went in with the predecessor to the Care Quality Commission to do an investigation into their rates of Clostridium difficile. Rose Gallagher was the infection control nurse, lead infection control nurse at the hospital at the time. And what we found then was that the executive team were not willing, or unable to hear any adverse messages. So staff were frightened to speak up openly. And when the infection control team did do a report to go to the executive, to the trust board, raising some concerns, it was altered by the executive management team. So when people try to raise concerns, they really, really should be listened to, because normally there is a basis behind it. Vexatious raising concerns is very, very rare. So what should it look like when you've got a good speaking up culture? Well, all these things here. You make it part of what staff do on a day-to-day basis. You know what's stopping staff speaking up, and you've got people who listen to them. And the fourth bullet point, I think, is a really, really critical one there. When somebody raises concerns, you don't focus on the person. It's not like, oh, it's just Chris. She's always telling us there's a problem here. You don't focus on the person, you focus on what Chris is telling you. And you're willing to learn, willing to embrace new ways of working, and that speaking up is followed up, and then you could see changes happened. Now, when I was chief nurse, or director of nursing, as the title was, at Western General Hospital down in Weston-super-Mare, we had boards up, and we had on those boards from patients, you said, we did. What we didn't have, and I realise that was a mistake now, when staff spoke off, we didn't have a you said, we did. We did it for the patients, but we didn't do it for the staff. So very simple things like that will help encourage people to tell us when we're getting things wrong and what we need to do about it. So if you have to speak up, what's the best way to do this? Be clear, be specific, and be clear about what are the facts behind it and what your views and your feelings are about this, so that there's a distinction between them. There is usually in your policies a way of following speaking up so that you go to certain people. But the best way usually is your immediate manager or the person responsible. That your policy will tell you who else there is to speak up to. There will, all NHS or NHS funded organisations have to have a person who is a freedom to speak up guardian or the freedom to speak up lead. And NHS organisations have to have a non-executive director on their board who has the responsibility for freedom to speak up. So there will always be somebody that you can go to. Different ways you can do it: email, telephone, other written methods. And you need to consider how you want to do this. The difference between these is openly is you're raising a concern and you're saying, I don't mind anybody that you need to speak to knowing that I brought this concern to you. Confidentially is when you go to somebody and you say, I'm raising a concern. I don't mind you knowing all about it, but please, when you take this higher or when you speak to other people, please keep me confidential to this. And anonymously is exactly what it says. So you raise that concern without there being any recourse or anybody not knowing. Now, it's important that you think about this, because freedom to speak up guardians and senior leaders will tell you that when concerns are raised anonymously, it's sometimes harder to deal with because you can't have that open and honest conversation with somebody about exactly what is going on. It doesn't allow you to go back and sense check that what you're doing or what you think you've heard are the right things and what you think you need to do are the right things. So yes, sometimes you have to do it anonymously, but it's harder for the leaders then to take that forward. And if you do have to speak up, it will be normal to feel anxious or nervous about it. Some of you I know are in senior leadership positions, but if not, as I said, you're all leaders around infection prevention and control. So these are the things that they say are really good behaviours for leaders to encourage a speaking up culture. The thank you, the listening, the protecting somebody, being aware of what barriers there are, creating opportunities for speaking up, improvement huddles, feedback sessions, the giving feedback and celebrating. These are really, really important things to make it positive within the organisation and to make sure that people are listening to you. So I have experience myself using speaking at policy when I was the Dipsy again at the Bristol Royal Infirmary. And this was at the time when the new variant of Creutzfeldt-Jakob disease, the mad cow disease, had started to raise its head in England. And we had not a lot of information about transmission routes, but we knew that it was a novel type of organism. We knew that it was resistant to our traditional ways of sterilising, and that the cleaning process to remove the organism was one of the most important things that we could do to prevent transmission. At that point, the research hadn't been done to know which body tissues were the critical body tissues around transmission of variant Creutzfeldt-Jakob disease. We knew with the traditional types of CJD that it transmitted through brain, spinal cord, and possibly some of the lymph tissues, and there had been evidence of transmission during some surgical procedures from one person to another of the traditional Creutzfeldt-Jakob. So it was all a bit of an unknown. And there'd been, as often happens in healthcare, we have the boom and bust about investment. And we've been at the bust point about investment in healthcare services. So the sterile services departments in hospitals have had a really bad investment. There've been no money, capital money to buy surgical instruments. So the government came up with a big pot of money to enable the sterile services to be upgraded with good washers, disinfectors, and to purchase surgical instruments. That pot of money came into our organisation, and the finance director grabbed it with both hands and spoke to our head of the estates department, who oversaw the sterile services department, about the money, didn't speak to me or our microbiologist, and decided that the whole of the money that was coming in was going to go for upgrade of the sterile services department. Great, that was one aspect of it. But myself and Bob Spencer, my microbiologist, we knew that we had sets of surgical instruments in some of our services. Orthopedics was one of them, that were rusty, that were damaged, and they are more difficult to decontaminate than ones that aren't rusty or damaged. And we knew there were a lot that needed replacing. And this money had been sent to do the two things: sterile services departments and surgical instruments. So we discussed this with the finance director. We went to see him. We had a really good relationship with the finance director. We sat and we had a meeting with the finance director and with the head of estates, had this conversation, and their view was, no, that's where the money needed to go. So me and Bob Spencer, we wrote a letter. We raised it in writing first because we thought that was the most important way that we should do it. So we wrote the letter to our director of nursing, who was the executive director for infection prevention and control, even though I was the Dipsy. She had a conversation with the finance director and with the chief executive, and all of a sudden, additional money from the organisation was found to purchase surgical instruments. So I had a really, really good experience of speaking up. When I did it, it worked, and it was an extremely positive outcome. That's not always the way. And this is a current example of what is going on in Scotland. And I know we've got a colleague from Scotland who is here at the moment. And there's a current inquiry happening, the Scottish Hospital Inquiry, that's investigating the construction of the Queen Elizabeth University Hospital campus, Glasgow, and the Royal Hospital for Children and Young People and Department of Clinical Neurosciences in Edinburgh. And when these hospitals were built, after patients were moved in, they had significant problems with organisms. And here we go with some of the longer names now: Stenotrophomonas multifilia, Klebsiella, Pseudomonas species, Serratia marthesans, and Aspergillus. Now, a lot of those are environmental organisations. So talks to us about problems with the environment within the hospital. And what the inquiry has found so far, and they haven't concluded yet, but the evidence that has gone into the inquiry so far has talked about problems with safety of the water, drainage and ventilation systems, non-compliant taps, high water counts of organisms, inadequate ventilation filtration in bone marrow transplant units, inadequate negative pressure isolation, and an inappropriate placement of at-risk patients. And there are two very senior microbiologists and infection control doctors that have given evidence to this inquiry. And I hope you've been kind of reading while I've been telling you the background of the inquiry there as to what their experiences are. One of them, personally bullied, shouting and criticisms. People were terrified of speaking up and they would be challenged. One of the senior ones being involved because people were afraid to speak up. And whistleblowers were criticised. One of them repeatedly tried to raise her concerns with managers for 3 years there. 2014 aware of problems, 2017 hadn't got the traction and whistle blew at that point. I think this quote here, the fourth bit down there, intimidated by the very large number of senior board employees at a meeting. Tone of the meeting was set when the board director cut short their introduction. Somebody at senior level not listening. And at the bottom here, 2 occasions when they're shouted and sworn at by a manager in front of colleagues and fearing that they would be physically attacked. So sadly, speaking up doesn't always have a entirely positive outcome, but it's important that people, if they are really sure they've got something to speak up about, that they follow it through, because the implications for it are extremely severe. So there are people that are there to help you within your organisations. If you're NHS organisation or NHS funded, you should have a freedom to speak up guardian, and there is a national guardian in England. In Scotland, there is an independent national whistleblowing officer as well that you can go to. There are always professional organisations that are there to help you. For example, the Royal College of Nursing and the others, Unite, Unison. The quality organisations like the Care Quality Commission and Healthcare Improvement Scotland, they will usually have somebody that you can go to if you've got concerns. Health and safety, patient organisations as well, like Health Watch or Patient Advice and Support Scotland, will always listen to you as well. And there are these charities here that will help you. The two particularly that the National Guardian's Office in England ask us to mention when we're doing any training on speaking up are Speak Up Direct and Protect. So useful that you know these if you need to speak up, or if you have any colleagues that need to speak up, to know that there are people that can help you. So speaking up then leads us into the next bit of this session, which is about having difficult conversations, because it's always difficult to start that speaking of process up. But difficult conversations won't always be about raising concerns like that. And the type of difficult conversations that we'll have at work could be about performance issues, could be about work conflicts, differences of opinions. If you've got to give somebody some negative feedback, if somebody's having personal issues that are affecting their work, sometimes career development discussions can be difficult conversations, and policy violations, which is a key one, I think, around infection prevention and control, because this is often one of the areas where we have to address practice and address some poor practice in the workplace. But they're difficult to have. I'm sure some of you have had these conversations, and I'm sure some of you have sat there now could think about why you didn't want to do it. Some of these things would have come up for you: lack of confidence, rejection, hurting feelings, not clear what you wanted to do, and if you've had a traumatic past experience in the past about speaking up. So the about having a difficult conversation. So apart from my speaking up, which went really well, I've had to have lots of difficult conversations at work, but probably one of the most difficult ones that I had to have wasn't about infection prevention and control. It was about making somebody redundant. I have never in my life had to tell somebody that their job is becoming redundant. And this was after a staffing review that had happened. And I was given the task of telling this person who was part of one of my teams that their job was going. It was made really that much harder because I knew my team well. I always make sure I know my team. I knew this person had just taken on an additional mortgage to be able to do some home improvements. So I knew this was going to hit them really, really hard. And having never done it before, having felt really anxious about doing this, I had to stop and think about how I did this. Luckily, at the time, I only lived 10 minutes from the hospital. So I went home and got my head together first before I had the conversation. So I stopped and I thought about it, thought about what I needed to say. I was really nervous coming back into having the conversation. I was really upset that I was having to have this conversation. And the outcome of the conversation was, as I anticipated, was the person got really, really angry and they actually stormed out of the office. Not unexpected, not unsurprising at all. One of the worst experiences that I've had to do, and even talking about it now, it's uncomfortable for me because I'm not naturally the kind of person that likes to have those kind of conversations. But sometimes we do have to do it. So it does help to prepare sometimes. So I'm going to share with you just a couple of tools you can use for having these conversations. There's lots out there. If you Google this or if you go online, you will find lots of different frameworks to help you have a difficult conversation. The coin one here, we're going back to the mnemonics here. Do you remember when we were saying in communicating messages about how you use this short, sharp? Coin is context, observation, impact, and next steps. So when you're describing to somebody why you're having this conversation, you're telling them the circumstances, the event, or the issue you want to discuss. You start with that. Then you go to the observation. Be specific and give factual descriptions as what has happened. One of the worst things you can do in a difficult conversation is to bring in your feelings or third party stuff. It needs to be what you've actually observed and can talk about factually. The impact of what this is having, either on you yourself or on how it's having on your team, and the next steps, having a clear agreement, because it's no good having a difficult conversation and then not being clear about how you can help somebody if it's about behaviours or about making sure that a certain event doesn't happen again. So that's the coin framework. The next one is an easy framework. Easy, it should probably be EEEEESY rather than easy, but that's how it's framed. And it's very similar, but it's have the evidence. What have I seen? What have I heard or read that I can share with this person? Expertise. What does my training and experience tell me about this conversation that I need to have? Empathy. That's why I like the easy one, because it's asking you to think about what might the other party be feeling like now. What can I ask about them to find out more? So as opposed to the coin framework, I think this one is more about it being an equal conversation rather than a difficult conversation. And then exploration. Apart from what I want out from having this conversation, what other options could I be open to if the person raises that? So that's just a couple of frameworks that I think can be useful for you in your practice to think about how you have those conversations. Now, what I'd like you to do now is go back into your groups again and have a discussion on any difficult conversations you've been involved in. Think about them, just discuss them. Did you use any of the frameworks described? If not, did you use another framework, and how helpful was that framework? And what can you take away from these frameworks for any future difficult conversations that you might have? So just think about those frameworks, think about any other frameworks that you've got. What can you take away from this session going forward? So we're going to go back into the same groups that we had. I'm going to give you just 7 minutes, just a short one about this. We're not going to do formal feedback on this one again, but if any of you, after you've done the group work, want to come back, and give us some feedback. I will give you an opportunity to do that.
In our group, we were just talking about how sometimes it can be really awkward, especially if you're telling colleagues, like one of the ladies in the group was saying about when you're challenging somebody to be bare below the elbows, it can sometimes feel very uncomfortable and very awkward.
Yes, it can, and I have this real problem because we talk about challenge, and this isn't a criticism of you, Nikki. We all say that we talk about challenging poor behaviours and bad practice like that, but automatically the minute you start saying challenge, it makes it feel like it's going to be a conflict and difficult, doesn't it? It's really weird that we use that word rather than come up with another word. And unless anybody can tell me otherwise, I've looked at the literature about this, about how you get a good result from giving constructive feedback on poor practice rather than challenging poor practice. And there's very little. There's a lot about how you give feedback to students, but actually on how you give constructive feedback to more senior people or something like that, there's hardly anything. And there's nothing that I could find that is actually infection control specific. So I think there's a big gap in the literature there to help us do that. Because you're right, it can be really, really difficult. One of my clinical directors was a little devil for me finding him on the ward with his watch and his jacket on. And I just used to sidle up behind him and say, "Nice watch, doctor." And do it that way rather than turn it into anything difficult. But I know there's times where you do have to pull people aside and do it, which makes it more difficult. Did anybody have any suggestions how to make it easier? No. No. Anybody else want to share anything from what you talked about? No? Yes, go on, Faith.
We discussed about professional development, how that conversation can be very difficult, especially if you're in a ward-based setting.
Yes.
And you're just, let's say, 10 nurses, and the manager is finding it difficult to lose one more.
Yeah.
To probably go for studies and how to negotiate the rota to accommodate your study days. That could be quite a difficult conversation. And it's from the conversations we've had, I think it's generalized in most wards.
Yeah. Yeah, even really tricky at the moment with the staffing levels like they are, but you can approach it a little bit from one of those frameworks, but also link it back to the other session that we did around the leading and the communicating IPC, and think about like your elevator pitch for it: short, sharp, precise, showing that you understand the problems about this, but the benefits of this could be better because how you might want to approach that. Well, I'm not telling you how to do this, but just what's instantly popping up into my head is how I would kind of have that conversation would be around, yes, I appreciate this is really, really difficult. So I wanted to do this IPC course and I wanted them to give me the time for it. It'd be, yeah, and I appreciate it's really, really difficult at this point in time. We know that IPC is a priority for us and for the organisation and everything. And actually, this could help us with our retention of staff if they see that we're willing to support people to do these things, and that if we're focusing on patient safety. So, that's the kind of way round that you might want to have those conversations. Think it through. It is about preparing for these conversations and not going in blind. That is probably the most important thing. So just a couple more tips that I want to share with you before we finish. Okay, some useful phrases that you might be able to use. These are on the PowerPoint slides, but so you'll have these anyway. Something I'd like to discuss with you, a bit sensitive, so may I just describe how it looks to me? A good starting one so that people know what the conversation is not going to be, oh, what did you have for tea last night? How do you feel about that suggestion? Help me understand how that presents a problem for you. What issues do you think we should consider in deciding this? What would be the effect if we let me make sure I understand what you're saying? So some useful phrases that you can think about. You don't want to sound like you've swallowed a management textbook, but having some of this how you might be able to construct some phrases might be really helpful for you. And some other tips. Don't put it off for too long. It will only get harder. Now, this next bullet point, a do-over. I've only just come across this, and I wish I'd known about a do-over before. A do-over is how you can sort of restart the conversation. So the examples are, that didn't come out quite right. Can I try that again? So if you start the difficult conversation and you can see that it's like, oh, then you've got a phrase like that that you can use. Didn't come out quite right. Can I try that again? I'm concerned some of the things I said aren't helping. Can we start over? Things didn't really go the way I was hoping when we talked. Could we rewind and try having that conversation again? So it's almost like resetting. If a difficult conversation's going in a difficult direction, it's almost saying, right, okay, let's start again and see where we go from there, rather than carry on in this way that it's escalating. But some phrases there that you can use. Don't use irritators, e.g., with respect, I hear what you say, but if you say to somebody, I hear what you're saying, but that's a red rag to a bull, and you're basically saying, I'm not hearing what you say. There are other ways to talk with people rather than actually saying that. Try to focus on common ground and take feedback yourself. If it's criticism of you, if it's on the topic you're talking about, accept it. You don't have to accept it if it's on a different topic or anything, because some people would just fire that back. But if it's criticism of you, take it and say thank you. That's one of the most important things you can say if anybody's giving you feedback, is to say thank you. Or if you don't understand what they're saying, to say thank you. Can you please explain a little further to help me understand? So you're helping that person with a difficult conversation that they feel they've got to have. So what we've done in this session, we know that raising concerns is part of our professional accountability. A good speaking up culture improves patient safety and staff retention. The evidence from healthcare in general is that speaking up is not easy. Speaking up can be harder for some minority groups, but there is a cultural change towards supporting people to speak up, and there's NHS and external structures that can support in speaking up. And for difficult conversation, there are frameworks that can help us prepare for them. And I'm just going to come back to this. The longer you put off the difficult conversation, the more difficult it's likely to become. So what we are going to look at in this legislation and regulation, the regulators, code of practice, and look at how you provide assurance in your workplace. So legislation and regulation are different. The law is the law, and it's based on and meant to carry out a specific piece of legislation, such as the environmental protection laws. Regulations are enforced by a regulatory agency who are been formed or mandated to carry out the purpose or provisions of a legislation. So the law is the bit that's done by Parliament, and then the regulations sit underneath that to make sure that law is implemented. Okay, so the law is the only legal obligations and restrictions that can be enforced by law. Just a reminder that healthcare and the law is devolved from central government to the 4 countries, and I know that we do have somebody from Scotland on this, and I know some of you do cover other areas as well. So I will try to make sure that we cover not just England when we do this, but a lot of it will be focused on England, but will be similar in the other countries. So one of the regulators that we've got to be aware of, I don't cover the General Medical Council because we rarely have doctors on this course, but Nursing and Midwifery Council, that's a regulator that sets out the rules around fitness to practice. And I will show you later on how that links to IPC. So the regulatory requirements here are compliance with the NMC code. Okay. You've got the Health and Care Professions Council, and their rules are made under the Health Professions Order, and they have something similar to our code of practice that they have to the NMC code of practice that they have to comply with as well. But the bits related to IPC there reasonable steps to reduce risk of harm. Do not do anything which could put the health or safety of a service user, carer or colleague at risk. So the regulators will take action, and they have taken action when it comes to infection prevention and control. And this one you can see here is a dentist, and they're registered under a particular dental register there. And the dentist and practice manager were struck off, reusing surgical instruments and not changing gloves. In 2000, Finchley GP was struck off. 30 patients contracted hepatitis B. This GP wasn't doing normal GP practice kind of stuff. They were doing homeopathy, and it was the acupuncture needles that they weren't disposing of or managing properly. And 30 patients with Hep B shows you how transmissible hepatitis B is without being vaccinated against it. 2014 there, Birmingham nurse was struck off. It wasn't just for infection control, but these were the infection control things that were cited: no apron worn, didn't remove gloves and clean hands after an MRSA patient. So, you know, ongoing poor practice there. 2015, Shetland nurse, again, not just the only poor practice, but one of the things that was said there, she was falsifying infection control audit data. So these were hand hygiene audits, and she wasn't doing the audit, she was just putting in poor data there, and struck off. 2016 here, Nottinghamshire dentist struck off. 4,526 patients had to be tested for hepatitis C, and only 5 were found to be positive out of that, which shows you the risk of transmission for Hep C is less than Hep B. And the poor infection control practice there, not changing gloves, not putting on new surgical masks. I love this one here, or I don't love it. Wiping his hands on his tunic or trousers instead of washing them. And issuing antibiotics to patients without diagnosis or checking whether they've had any allergies. So linking back to the antimicrobial stewardship there as well. So the professional regulators will take action against people for poor infection control practice, and that can go as high as striking off. The Medicines and Healthcare Products Regulatory Agency, they are for the UK. Their role is to make sure that the medical devices that we use in the UK are safe. This comes medicines, medical devices, it covers here. The legislation that the MHRA, the Medicines and Healthcare Products Regulatory Agency, work to are the ones there: Consumer Protection Act, Medicines Act, and there's the 2 regulations that they have there: the medical devices regulations and the general product safety regulations. Now, this is infection control related for one of the actions they took here, and it was a company that were supplying total parenteral nutrition at a site in Runcorn, and routine monitoring of that showed that they had microbial contamination in their production area and on production personnel: Bacillus cereus and Bacillus thuringiensis, and Bacillus and some mycoides were also discovered there as well. And what they did is they went in and inspected, and they saw that their production processes were not in compliance and presented a potential risk to patients, and they took immediate action to instruct the company to implement changes. So they didn't close them down, they made them take immediate actions. That was their regulatory action at that point. Now, where the MHRA are involved in the sort of the hospital setting is around making sure that the companies that supply you with some of your sterile products, Smith and Nephew, BD, that their products are safe for you to use. But in addition to that, if you have a sterile services department that is supplying products to a third party, so outside of your trust, so say they were supplying it to a community or to GP practices, then they are covered under the MHRA regulations, and they have to operate in such a way and be inspected to make sure that that product is safe. So that's where the MHRA comes in relation to infection control. Health and Safety Executive, I mean, you all know the Health and Safety Executive. 2 key pieces of legislation there: the Health and Safety at Work Act and the Control of Substances Hazardous to Health. Now, for IPC, COSH relates not only to the chemicals you use, but microorganisms are classed as substances hazardous to health, which is why in the laboratories they will have procedures that they follow for certain organisms that are more likely to cause hazards to the laboratory workers than others. So the COSH regulations apply to that. Even for you guys working on anybody working on the front line, COSH applies when you're doing something like emptying a catheter bag, because urine would be considered a substance that's hazardous to health, and we've got to have the controls in place, so the right protocols in place to protect you as much as possible when you're doing that. So what about non-compliance related to IPC when it comes to the Health and Safety Executive? Okay, Worcestershire there, Alexandra Hospital there, they were prosecuted for 12,500 for a member of staff who contracted hepatitis C. The staff member had worked at the trust for 3 months. They'd been told to take blood, but they hadn't been told the infection status of this patient, and this patient was known to be hepatitis C. Okay, you're going to come back to me and say, what about standard precautions? But all the protocols for taking samples will say that if you know a patient has a biohazard condition, which would be hepatitis C, hepatitis B, tuberculosis, and there's a list of all other ones that come under the biohazards, staff have to know, because they have to be able to label it and send it onto the lab, and they have to make sure they're taking the right precautions. So whilst we have standard precautions, you should be told about patients with biohazards when you are doing procedures that could be a risk for you. So this member of staff, they were unregistered, they were a healthcare assistant, and they had difficulty reaching the sharps bin. So they put the needle on the work surface. The patient was bleeding, so they reached for a tissue and they caught the needle on their wrist. And the trust was criticised because it said the employee wasn't being appropriately supervised because they were unregistered. The risk assessment for that procedure wasn't adequate. They had had no training on the controls to protect them. So the sharps bin wasn't within use. So they hadn't had training that told them, take the sharps bin with you. And there was no oversight or monitoring of safe working. So no auditing of that practice. The next one down is Basildon Hospital with Legionella. They were fined 100,000 and 2 patients died. The Legionella was found in shower heads and thermostatic mixer valves that hadn't been cleaned. So bang to rights that they hadn't been following what the procedures are to prevent waterborne infection. The bottom one there is a care home in Essex, Hatton Village Care Home. These are all in the public domain, so I'm not telling you anything that is confidential information. And like I said, this is the care home here where somebody died, and one resident died of Legionella. And the judge in this case said the care home allowed Legionella to persist despite various warning bells since 2012, and no one had a grip on the risk in the village care home, and the company had shown a lack of remorse. So they were initially fined 1.5 million. They did appeal against that, and I think their fine was reduced by half. So the Health and Safety Executive will prosecute where there is significant evidence of breach of infection prevention and control protocols. Now, there is some infectious disease legislation that relates to IPC, and this is Public Health Control of Disease Act, where a justice of the peace can make an order that somebody who's infected and may present significant harm to human health can be detained. And they can order health measures in relation to premises. So I've known this used, the Public Health Control Act, once in my infection control career, and it was somebody who had multi-drug resistant tuberculosis who wasn't taking their medication and wasn't restricting themselves to their household. So a court order was put in for them to be housed in hospital. What we couldn't do was make them take their medication, but we could make sure they didn't present a risk to the public. And they can order health measures in relation to premises. So this would be like your food poisoning, and this is usually enacted by your environmental health officers through the council. So they can order somewhere to be closed down. So that's the legislation that allows people like environmental health officers to make sure that food premises are safe. The bottom one here is about notifying of infectious diseases or when somebody has died with infectious diseases. And the laboratories and the person who sent that specimen, usually the doctor, is the one who has this duty to notify suspected disease, infection or contamination to public health so that they can take the appropriate actions to make sure that it's not spread on further. And the kind of things we're talking about there would be salmonella, would be campylobacter, it would be something like CJD, it'd be something like TB. When I had campylobacter after a holiday in Morocco, and I did do a specimen because it wasn't clearing, and that was reported to the laboratory. They then obviously notified the local authority, and I had a phone call from somebody there doing the tracing so that they could see whether I was linked to any other stuff that was going on in the area, which clearly I wasn't. So that is the key infectious disease legislation. There is law related to infection prevention and control. And fortuitously on this slide, I've got the two things that relate in Scotland and in England. So it's the Health Act 2008, Patients' Rights Scotland Act 2011. And these both set out what patients can expect in terms of no avoidable harm. So these are the laws that then lead on to the code of practice, which Susie mentioned yesterday. There's the Wales one and there's the Northern Islands one, which I'm not going to read because if you want to go read the slides, you can. So in England, we've got the code of practice, and the main purposes are set out there. They make what you need to do clear. So for all of you, if you need to know what you need to do for IPC, the hygiene code of practice for the prevention and control of health and care infections, that's your Bible, that's what you go to, that's what you read. It provides the regulators with what they need to do to make judgments, provides information for the public. Within Scotland, they've got the IPC standards. And again, this supports organisations to quality assure what they're doing and against the IPC principles set out in the National Infection Prevention and Control Manual. And the Care Inspectorate inspects services using a self-evaluation framework here. Wales piggybacks really off the back of the England one, and Northern Ireland also have a set of standards as well. In the interest of time, I'm just going on past this because it's information you can read on the slides. But I'm just going to dwell on this slide a little bit. This is a comparison of what the standards are for England. And I have summarised them a little bit for Scotland, for Wales, and for Northern Ireland. But if you look across at the comparison of it, you will find that they are all very similar in what they're looking at. It's about having the leadership, the governance, and the systems. It's about having a clean and appropriate physical environment, a clean and safe environment. England mentions antimicrobial stewardship specifically, whereas the others don't. It's set within their things like and Scotland mentions it, but Wales doesn't. It's set within their policies and procedures. Risk assessment with Scotland, Wales and Northern Ireland, that's set within their section on leadership and governance and organisational structures. Staff are in there, making sure that staff are safe, having the right facilities, laboratory facilities, and it clearly focuses as well on the policies and procedures that we should have in place. So it's all set there, whichever country you're in, those standards are there for you to work with. So the 4 regulators work in slightly different ways, but most of the regulation is about being registered with somebody. Some of them will go on site and do inspections, and they may be planned inspections, they may be themed inspections, they may be reactive inspections due to raised concerns. Some of them use self-assessment. They all have a way of doing public reporting, and they all have a way of using information gathering and intelligence to tell them how well organisations are doing. This is as it stands at the moment, but as you heard from Susie's session yesterday with the new government in, it's a possibility that some of these things can change, but that's how it stands. So example of the CQC here. The right-hand side, the writing there, that was when they did a themed inspection of COVID precautions in care homes. And this was somewhere, I believe it was in Devon. It's certainly in the southwest. It's either Devon or Cornwall. And in this care home, they appear to have made a conscious decision not to follow the rules on wearing masks and gloves. And they couldn't justify why they had made that decision, but they hadn't, it wasn't the fact they didn't know they had to wear it, they knew and they decided not to. That home was in the process of being closed down due to that safety fear and other safety fears as well. So the Care Quality Commission can close premises down if they're significantly concerned about it. On the left-hand side, this was a mobile medical ambulance, and this was in, I think it was East Anglia this happened, and it was post-COVID. And when they inspected them, they found ambulances and medical equipment that were visibly dirty. So they suspended the service to allow the ambulance service time to deal with that. Usually the prosecutions and fines by CQC are not related to IPC. You often see them for things like handling of medicines, care planning or risk assessment. So bearing in mind that we're talking just about England here with the CQC, the other regulators work in a very similar way. And when you have an inspection, you will be given a report of what they found in your services with recommendations for what you should do and where you are breaching rules. So there may be some urgent stuff, there may be some recommendations, but what they will not necessarily come in and do is tell you how you address what you found. So it's really important that you understand that if you get some bad feedback on practice, that you know what to do. So I've given you an example of some really bad CQC feedback, and this was a private clinic, I think it was in the London area, that was doing cosmetic type surgery. And I've summarised the sheet that I gave you to read, but I'm sure when you read it, you were thinking, oh my God, I definitely wouldn't be going there to be having any surgery done. Poor cleanliness in clinical areas, furnishings not suitable nor well maintained, cleaning schedules not documented nor audited, no system in place to provide assurance of cleanliness, inadequate sterile field management, can't believe they were putting stuff out the night before, poor staff knowledge of sterile stroke aseptic technique, mop heads not stored or managed correctly. Sounds slightly insignificant, doesn't it, when you're talking about the sterile field stuff. Gloves not changed, hands not washed, no dedicated hand wash sinks, lack of systems to monitor for surgical site infection. And you've had the session on all surveillance of infections, and you've had Susie talking about that yesterday, so you know the importance of that. No risk assessments against environmental standards, and exposed concrete in areas undertaking surgical procedures. So what I'd like you to do now is to go into groups for 7 minutes again. So if we can start preparing that, Crystal, for us, get you to go into 3 groups, and you're going to address one of these questions each. So group 1, I want you to just discuss in general how you're going to address what the CQC has found there. Group 2, I want you to look at what would be your priority areas out of everything that's on there, because there's a lot to do there. Group 3, I want you to discuss what documentation you could have ready or you will need for when the CQC or that inspecting body comes back in to re-inspect you. How many of you were horrified when you read that? Seriously, I didn't make
I
it
wouldn't
up.
go in there.
Like, gee, yeah, really? Oh my goodness! It is a bit. Thanks for it. It is a bit of where would you start? So that was kind of why I did this. So let's go to group 1 first. Angela, you don't have to give feedback, but it's the group that Angela was in. So how are you going to address this? Whoever's
Well,
giving us feedback. Oh, thanks,
I
Angela.
think so. We spoke about, CQC can just send back the report to the trust, then tell them to make an improvement plan so that they send back the improvement plan to CQC. Then they plan on a day to revisit them.
Yeah.
So they go back, they revisit to see whether there's been any improvement compared to the previous visit. If not, one way they can also tackle it, when they send in the reports to them, they can tell them that anything in the report they do not really understand. They can make a date, like a date with them, sit with them, then they will discuss on it. Then they do the improvement plan and send it back to them for revisit.
Yeah. That's exactly how the process works with the CQC. I've never done one in Scotland, so I would imagine it's something sort of quite similar if they're doing that. I've been on the receiving end of a number of CQC inspections personally, and with the organisations prior to that. And I'd just taken over at Western General Hospital as director of nursing. Literally, I've been in the role for 2 days. And the CQC, the equivalent of the CQC prior to that, they came and did an unannounced inspection. They were there for a day. They came to me and they gave me examples of what was absolutely appalling nursing care. It was really, really awful what was going on. And they gave me 6 weeks to turn the organisation round. My first director of nursing job, my second day in the job as director of nursing. It was like, oh my God, where do I go? I was really lucky in that I had a lot of help and support from everybody around me to make that happen, and we did turn it around. But it was only with the the real support of staff that we did that. But it can be quite horrifying. But what the CQC don't do is come in and tell you how to do it. So it's up to the organisation to do that, and you have to put the action plan in place, as you quite rightly said, Angela. You develop your own action plan, and then they monitor you against that. So if you say you're going to do something, they'll come back and make sure that you've done that. So that's brilliant. Thank you. What about group 2? That's the group that Anique was in. It doesn't have to be Anique feeding back, but what are you going to be your priority areas? It looks like Nikki's feeding back to us.
I feel like I do all the talking. I'm happy for the others too, but I wrote it down. That was all. Yeah.
Anyway, go on, Nikki.
Is my group happy for me to do it? Yeah. Okay.
Yeah.
So we definitely need an action plan. So we talked about implementation of the National Cleaning Standards of 21, because that will cover the bits and pieces like there was no clinical areas, non-clinical areas weren't clean as well as clinical areas. There was no system or rota for cleaning. Weekly cleaning audits weren't adhered to. Lack of documentation and evidence of cleaning, lack of understanding in the housekeeping roles. So that should address that as part of the action. We also said there should be incident reporting regarding maintenance for things that were visibly dirty, things that were rusty, fabric instead of cleanable surfaces, holes in the ceilings, emanating dust and that kind of thing. So incident report that. So some maintenance will need to be, somebody would look at it.
Yeah.
And then we spoke about audits going forward, IPC, perhaps place audit, the National Cleaning Standards audit, and that together with IPC education for just about everybody, I think, and try and remove the blame culture. So just having an action plan around those things. Obviously, there will be different departments, but we thought that might cover it. So my granddaughter's just came in and she's just looking at me as if I'm mad.
Oh, lovely. No, thank you for that, Nikki, and for your feedback from the group. Yeah, that's absolutely your priority there. Focusing on the cleaning actually is going to get you a big bang for your bucks with that kind of thing. And there are some practices that you can focus on straight away, aren't there? Like the sterile services stuff. That can be right, that's just to you stop that. Some of the stuff's going to be slightly harder because like repairing things in walls. And I think what's significant about this one, it being private clinic, they probably had an external cleaning company in. which makes it harder then about the communication. They wouldn't have had an estates department like we have in a hospital to be able to come and do these repairs. So they would have had to manage that as well. So it just makes that prioritization slightly harder in how you do that and managing that. Okay, group 3, which was the group that Monica were in, what documentation could you have ready for this when the CQC come to re-inspect? It doesn't have to be Monica feeding back, it can be anybody from that group, but it was the group Monica was in. Thank you,
We've
Karen.
got quite a list actually. So I think the very first thing that we need to do is to provide assurances to CQC. So review or new policies or SOPs that should be in place to address the concerns. Then show audit schedules and results, cleaning checklists, equipment service logs or cleaning logs or whatever you call it. We also have to look into internal or external housekeeping SOPs because they did say it's an external agency, but I think we have to do a duty of care and see what exactly or how exactly are they going to be cleaning the rooms or areas that will be up to standard. And then waste management PPEs, I don't know if anybody uses it, but the light green, what you call it, RAG, red, amber, green, and make sure that the staff knows what what it is all about. And then for theaters, because they did mention sterility, ANTT training materials, just to reassure the CQC that we are doing that part. And then lastly would be your SSI records for any surgical site infections and a post-infection review.
Yeah.
That's what we thought of.
That's brilliant. You all did really well in that short period of time to look at that. There's a couple of things that I want to pick up from what you said there, Karen. One of the one was about the cleaning company, and because it's private, you're right, because this will often be done out of hours when nobody from the organisation will be around to supervise it. So the point that you picked up is, evidence that you're monitoring it and on it is probably something that's really, really important. So thank you for doing that. And you picked up, you actually said the word, which we're going to move on to now, which is about providing assurance to the CQC, because that's what they will be looking for, is assurance that you have done what you said you were going to do. So I'm going to just reshare my screen, and we're going to do just a little bit now on assurance and how you assure in the healthcare setting what you. So there is a difference between assurance and reassurance. Both of them are okay to use, and I'm going to show you sort of a balancing scale about that. But the questions you need to be asking yourself when you're providing assurance about how well your services are doing, your IPC services, do we really know what we think we know? Where does this assurance come from? How reliable is it? What is it telling me? And is the assurance proportionate to the level of risk the organisation is to take, or as to what's going on? So you mentioned about the hand hygiene audits, and it may be that you're doing the hand hygiene audit, say, every 6 months. And that might be all right for the type of organisation that you're working in and your levels of healthcare associated infection and your levels of risk. So it's, for example, if we were talking about a forensic type of unit, mental health unit, rather than a surgical procedure unit, that may well be okay, because the transmission of infection by hands is going to be far less of a risk than it would be in the surgical site. So you have to bear that in mind. And you balance the assurance and the reassurance. And I think these phrases are really helpful here. If you're getting reassurance, it's saying it's okay because management say it is, full stop. But there are dangers behind that, and you may have strong people and just relying on a track record. At the other end of assurance, you've got it's okay because I have reviewed various reliable sources of information. So there could be some independence here, so some external reviews, evidence of historic programs and outcomes, and triangulation with other information there. So not just relying on one source of information to tell you something is okay and it's happening. So if we went back to the cleaning, you would triangulate that with observation, with the audit reports that were going on, with the availability of all the SOPs and the evidence that people were trained against it. I know I've given you 4 things there, but that's what we're talking about when we're triangulating. And in the middle, it's okay because management have responded to questions from the board, and this has given me confidence. So if somebody has come back to you and said, yes, that we got clear and logical explanations to this, but you haven't necessarily got an independent resource, that's in the middle. And it depends what's happening as to whether you want assurance or you want reassurance. But something like that CQC, they'd be looking more for assurance than they would for reassurance. Reassurance might be all right when things are going okay. So for assurance within an NHS organisation or NHS funded, there will usually be somebody like the chief executive who is the accountable person there. If you think of like a GP practice, that will be the lead GP or the GPs that own the practice. If it's a nursing home, if it's individually owned, it would be the person that owns it. If it's a group home, there's likely to be a board of people with a chief executive who've got that accountability. All organisations that provide health and care should have a lead person responsible for IPC within their organisation. You notice I use the word then responsible rather than accountable. The buck stops with the chief executive normally. The responsibility, they can either be a director of infection prevention control, they can either be a lead person, but they will usually take the day-to-day responsibility for making sure things happen. Then normally there will be an infection control committee or a quality committee that regularly discusses infection prevention and control. For a small organisation, you wouldn't necessarily even have a separate quality committee. It may be that you have like a monthly management meeting, and as part of that, you have a quality section, and infection control would be part of that section. So it's whatever works for your organisation, but you should always have somebody who the buck stops with, somebody who takes day-to-day accountability, and some process within the organisation that you are monitoring and assuring what's going on with infection prevention and control. So in England, they've developed this board assurance framework, which is a way of showing how you are applying the code. For timing, I'm going to take you to that in a minute, but I just wanted to tell you about that before I take you to it, because I've got to go in and out of various different programs to show you that. This is an example of an integrated care board's assurance against IPC. So you'll see that it's a very, very high level one. When we're talking that level of sort of regional well, this is Bath, North East Somerset, Swindon and Wiltshire, that whole area, they will not have the very level of detail behind that on their performance. But if you go into their board reports, you might find something about individual areas where there's a problem. But what a good board governance report for a provider organisation for infection control should have is an overview of the current position, any surveillance or reportable healthcare associated infections, and any progress towards your targets like C. diff or bloodstream infections. You should be reporting outbreaks and incidents. You should include in their cleanliness standard in monitoring, and you should include IPC standards and policy monitoring. So your audit results, you have to think at what level you're doing this within an organisation and engage it according to that. And there should be linked subcommittee reports, for example, the Decontamination Committee, Water Safety Committee or Ventilation Safety Committee, if you have those in your organisations. If you don't, then there should be some way of monitoring that within your governance reports. And any risks that you currently have and any actions that you are taking in respect of that. So let's just share with you some different ways of monitoring assurance. Right, this is the England Infection Prevention and Control Board Assurance Framework. So it's an Excel spreadsheet. It's got the standard here, the manager monitors the prevention control of infection, the system use risk assessments and consider the susceptibility of service users, any risks their environment and users may pose to them. So you've got a whole load of questions down here that you can provide the evidence against it, say where you've got gaps and what you're doing against it. Then you can then score yourself as whether you're being compliant or not. And then when you click on this at the bottom here, summary plots, it gives you a visual of how well you're doing and overall. So that's one tool in England that you can use to provide assurance against the code of practice for healthcare associated infections. I'm now going to go to some other examples to show you. I think I have still to go back to this one. Bear with me, because we've now got to go through different toggle things on my video off. Trying to move the thing out of the way. Okay, so this is the Gloucester Health and Care Foundation Trust. So they're a community organisation. Their annual report for IPC. I've given you the links to these so you can go and have a look at them and get some things from them. But you can see from the table of contents, they are including the kind of things that I talked about. They got the team structure in there. They're saying what audits they're doing, and you can see the kind of audits that they're doing. They've got decontamination, they've got water safety, antimicrobial stewardship, patient information, there's surveillance, training and education, isolation facilities, laboratory support, policies, and staff wellbeing. And then they're saying what they're going to do next year. This one is for the ambulance service, so it's going to be slightly different. But you can see that they are still covering all the same kind of things within there. So the team structure, the learning and development, the risks, the incidents, they're covering vehicle and premises cleanliness audits. And then there are appendices, they're talking about their flu vaccination programme. This is a primary care practice group. And primary care have to have this infection control annual statement, which you can see there. It talks about what we're doing, says who the lead is, talks about any incidents that they've had, audits and actions, risk assessments, training, policies, and everything there. So just on a slightly lesser level than you would have in somewhere like a large teaching type trust. And this is from Marie Curie, the charity, who obviously provides hands-on care, etc. So they have to do the same thing there again. So you've got exactly the same. They do their compliance with standards, their governance arrangements, incidents, their work programme. They talk about their linkness network. This one was during COVID, so they talked about their response there, and they included the board assurance framework, policies and procedures, surveillance, incidents, and all the way through the same kind of things. They include sepsis in there, which I think is really good. Antimicrobial, training, occupational health, water safety, estates and facilities. So the idea, I didn't have time to go into detail about those because the idea was just to give you guys an absolute overview of what should be in there for assurance. Those links are in the slide pack, so you'll be able to go in your own time and have a look at them and learn from there. And it'd be really lovely now if, guys, you could pop your cameras on, because I'm finishing that session now. And we're coming to the end of this, and it'd be lovely to see you all before we all go. So if many of you have got cameras, it'd be great if you could pop them on for me now, which would be lovely. And I'm going to ask first any questions about the session that I've just done, the regulation and assurance. Any comments on it? Any of you think you've got really good reports and things that you do, pop them in the discussion forum, because it's about learning from each other. So if you can, that would be great. Okay, well, it's the end. That's the end of the talk bit now. I'm going to get Crystal to put the evaluation form link in the chat for you. We really, really want your feedback. I'm going to carry on chatting. You can ask me questions or comment on anything while I'm doing this. Marie, don't feel free to pop your camera off. Mine, it's fine. Don't worry. So if you could fill in your evaluation forms for us, that would be absolutely great. Thank you very much. Thank you to you guys for being a great group and for participating well in all the group work that we've done. Thank you for coming on the course.